So I welcome everyone. We see Dr. Umar Ehsan, we see Paryam is here, Dr. Nadeem is with us, Dr. Fareed, Dr. Elias. Dr. Elias, are you able to listen or are you still struggling in this one?
Yeah, fine. Yeah.
Yeah,
Now I can listen. Thank you.
that is great actually. And there is Fad Memon also, and Ghulam Ali is with us. So this is we're discussing about the carotid artery disease. This is a small lecture series, and we are being connected with CMH Rawalpindi soon. Dr. Imran was presenting on TIAs and focal neurological deficit. And the first topic we are discussing about that, what is the clinical presentation of different carotid stenosis maybe, and how they can be what is the pathophysiology for that. So I suppose Dr. Imran is back and we can listen him.
Strokes are described as large, which is regional or small lacunar and are directed to a particular area of the brain. Now, sir, I will come to the signs and symptoms of the stroke. The hemorrhagic stroke signs and symptoms are sudden and dramatic, violent explosive headache, visual disturbances, nausea and vomiting, neck and back pain, sensitivity to light, weakness on one side, can present like a migraine headache. Now the signs and symptoms of the ischemic stroke include, it is usually harder to detect, weakness on one side of the body, facial drooping, numbness and tingling on the sides of the face, language disturbance and visual disturbance on the ipsilateral side. Now the right side of the brain stroke include the symptoms of the left side of the brain stroke include right side paralysis, speech and language disturbances, behavioral changes, and solving problem. Now the right side of the brain damage include the left side paralysis, spatial perception, coordination problems, and perception recognition of the familiar object. Can stroke be prevented? Yes, there are some modifiable risk factors which can decrease the prevalence, the occurrence of stroke, which include if we control the BP, stop cigarette smoking, alcohol intake, uncontrolled heart disease, atrial fibrillation, uncontrolled diabetes, carotid congestion, high blood cholesterol, sedentary lifestyle, obesity, seasonal, it is usually occurs more in the spring and fall, and stress. Other risk factors include personal or family history of stroke, heart attack, or transient ischemic attack. Age more than 55, race, African and American have the high risk of stroke than do people of other races. Gender, men have a high risk of stroke than women. When women get older, then their chances of strokes become higher. Now, the causes of the carotid territory stroke. Usually, the carotid territory stroke are due to the thromboembolism, and percentage-wise is divided into number first, internal carotid artery or middle cerebral artery. It contributes 25% to the carotid territory stroke. Small vessel intracranial disease contribute 25%. Cardiac embolism contribute 20%. Other specified rare causes contribute 5%. And unknown causes, despite investigation, includes 25%. Now, methods of measuring the carotid stenosis. There are two trials. One is European carotid surgical trial, and the other is North American symptomatic carotid endarterectomy trials. I won't go into the details of these trials, but simply there are two formulas for the determining the percentage of stenosis. In the NASCAR trial, which is North American symptomatic carotid endarterectomy trials, it is 1 minus nominator divided by denominator into 100. And the ECST is 1 minus nominator divided by denominator into 100. The difference between the two is the denominator. In the NASCAR trial and the ECST trial, the denominator is the same, which is the minimal residual luminal diameter. If in the slide, if you can see, the n is the denominator. And if you want to calculate the percentage of stenosis, then the denominator will be different in both the ECST and the NSCT. In the NSCT, the denominator is the diameter of the residual internal carotid stenosis where there is no diseases, and usually it is parallel to the external carotid artery. And if we come to the ECST trial, the denominator is the estimated luminal diameter where the stenosis is measured. So in these two trials, there is usually discrepancy. If the percentage comes out in the NSCT trial is 50, and then it will be 70% in the ECST trial. I hope you will understand it from this side. If not, I will share this slide later, from which we can calculate it very easily. Now, new imaging strategies. Duplex ultrasound is usually the first line of investigation because of low cost and accessibility. Duplex ultrasound use a peak systolic velocity and diastolic velocity and their ratio in the internal carotid artery and the common carotid artery based on the Nasket measure method. The second one is the CTA, contrast CTA. And the contrast, third one is the contrast enhanced MRI. If a patient is if patient cannot be given contrast, then without contrast MRI is also can also be done. Catheter angiography is now rarely required unless there are discrepancy on non-invasive images. These are some recommendations, but because of the less time, I will complete my presentation here. Thank you so much, and I will Dr. Saqib will now continue his presentation. Do you have any questions?
Yeah, I suppose this is very nice presentation, and you have nicely described type of stroke.
Sorry, Zia, for this problem with the connection.
Yeah.
So we will presentation will be fine.
Yeah,
so
no.
I'll disconnect for a few minutes and then reconnect again.
Yeah. I asked the participants if they have any comments or any questions, they can raise their hands and we can participate, and that will be fantastic. What is their first line of investigation when they are doing carotid stenosis, and especially for screening? And what is their first line of investigation when they are planning for any intervention? Any comments, any thoughts of that? And what is their experience of in their local setup of using duplex scan versus CTA, anything else?
These comment. Duplex is unfortunately not at all a reliable investment in Pakistan.
Dr. Umar, voice is, we are having a problem in listening your voice, but you are rightly said that ultrasound has a problem. Yeah.
Scan turns out to be that is in our own setup. If I get a duplex report from outside, especially from somebody who idea what the who the radio, either I repeat the duplex or go straight for CT angio.
Very nice comments. That is great. And to understand that we have to communicate with the radiologist whenever they are seeing for the CT scan, although we are CT or ultrasound, although we are relying on the degree of the stenosis, But we know that beside degree, it is the composition of the plaque, which is also important. For example, the plaque can be vulnerable or it can be non-vulnerable. It is a stable plaque. So if we communicate with the radiologist, they can show the signs of vulnerable plaque. The vulnerable plaque will be looking like a evolution. It will be having an ulcer. There will be intraplaque hemorrhage. There may be in situ thrombus there, but stable plaque will be having more of calcification, and it will be having no intraplaque hemorrhage, and there will be no ulceration. So beside degree of stenosis, maybe the composition of the plaque is as important as in decision making of this plaque. And I agree with Dr. Umar that when we are planning, we always go for a CT or a more objective investigation, either CTA or MRA. I suppose Dr. Saqib is ready for the next presentation.